Morning, Pudney, and welcome everybody to Medical Grand Round this week. For those who don't know me, I'm Chris Watkin, and Jo has asked me to chair in her stead while she's unavailable this week. And I'm pleased to welcome Professor Stephen McDonald to speak to us today. He is the Director of Dialysis through the local service base, the Royal Adelaide Hospital, as well as a consultant nephrologist, and is the Clinical Director of Renal Services for Country Health, which is fitting as he speaks to us today from Whyalla. He is also a clinical professor through the University of Adelaide Department of Medicine and Principal Research Fellow at the SA Health Medical Research Institute in Samri. He's going to speak to us today on the topic of why are there so many dialysis patients and how can a CQR help? So thank you very much. I'll hand over.
Thank you very much, Chris. Can I just check that people can see my screen?
Coming through nicely.
Excellent. So look, thank you for the invitation, and thank you for the introduction. And I'd just like to add to your words my acknowledgement of country. And I'm actually on Kaurna land out of Gawler at the moment rather than Whyalla, but I've put a couple of relevant lines of hats that I wear on the title slide, because I'm going to, I guess, talk about a slightly non-sexy topic today. There's not going to be too much revolutionary statistics. There's certainly not, sadly, going to be pictures of islet cells infiltrating subcutaneous implanted skin or any of the other wonderful work that goes on in the renal unit, but really some topics that touch us every single minute of every single day, and increasingly are affecting the hospital and the health system around us. So, which is really why do we seem to have so many dialysis patients, and we'll walk through what the problem is, why it's occurring, how do we know that it's occurring, and there's a little bit of a sideline there about CQRs, and then talk a little bit about what's going to happen into the future. So those of you who have an involvement in bed state at a hospital or broader level will have some visibility, I think, of some of the issues around bed capacity. In terms of hemodialysis chairs, though, there has been a steady increase in demand. There's not been a steady expansion of supply, and that's really now in the last 12 months or so reached a particularly acute stage rather. Through the renal community of practice, we collect and publish each month the so-called dashboard, and this is publicly available on our website, of the various dialysis units and their capacity or lack thereof. And the salient features here are that all of the metropolitan units, all of Callan's units, all of Sallin's units, all of Nalland, or Nalland only run one unit at Larmicoon, all are actually over capacity and have substantial waiting lists. The Ross Hills Fluria, where I am now, the Perry Metropolitan Penumbra, if you like, also are full, and so there really is a situation now where in the public system there is no capacity. In the private system there is also no capacity, and that in fact reflects not the overwhelming attractiveness of private health insurance to dialysis patients, but in fact what we've used as a method of coping over the last few years. So we really are at a point now where the hemodialysis chairs in this state are full, and that's led, as you might imagine, to a number of coping strategies, a number of discussions. From the patient's point of view, there are an enormous number of consequences for this, and one of the really important ones is that if you look at how the health system and dialysis chairs in particular are organised, it looks like a bit of a mess on a map. And if you think that treatment of patients close to home is important and is an ideal, then you can get a feel from this spider chart of how well or how not well we are doing. And you can see both on the south side of Adelaide and the north side of Adelaide, there are people travelling past one dialysis unit to go to another. There are people travelling up past Noarlunga to go to Brighton, to go to Flinders Medical Centre. There are people travelling to Gawler from the who should be going to Lyle McEwen Hospital and so on. And these are inevitable, if you like, outcomes of a system that's under stress, and a system that very clearly therefore delivers less than optimal care for patients, certainly in quality of life, and that has a whole lot of knock-on consequences, of course. Underlying this has been, as you might expect, really very little growth in metropolitan dialysis chairs for some time. It's worth noting that there has been this, and you'll see when I show you in a few minutes, this very steady growth in dialysis numbers in South Australia for some time. And one of the success stories, if you like, of the last 10 or 15 years has been the building of infrastructure in regional areas. And so the number of dialysis patients now being managed out of Adelaide is much greater than it was, and the flip side of that, of course, is fewer are in metropolitan areas. But it's obviously reached a point now where in the metro area we are in a situation where the inn is full. So this is not just a South Australian problem. If you look across the country, and this is obviously 20 years of data is from the ANZ Data Registry, which is the National Dialysis and Transplant Registry, which is based at SAMRI. You can see overall the growth of numbers in what's now called kidney failure with replacement therapy. So the terminology around this has changed in the last 12 or 18 months, and that reflects, in fact, some engagement with consumers and some major consumer conferences. We, for many years, have talked about end-stage renal disease, and then more recently end-stage kidney disease and so-called renal replacement therapy. The very clear message from a number of these conferences is that consumers or patients wanted what was historically called end-stage kidney disease to be known as kidney failure, and the collective term for dialysis and transplantation to be called kidney failure with replacement therapy. So as you hear these terms into more common usage, that's the background. So that's the situation in Australia, and you can see very clearly over the last 20 years, there's been a more than doubling of number of prevalent patients who have one or other form of kidney replacement therapy. And similarly in South Australia, the trends are no different in terms of the trend upwards. There is, you'll see, an important difference though in that the proportion of people who have a transplant compared to dialysis historically has been greater than in South Australia, which reflects relatively stronger organ donor rates. Now that the top part of the graph, if you like, don't impact on dialysis services. And so when you focus just on the people who are receiving one or other form of dialysis in South Australia now, you can see this and extended actually now out over 30 years. And you can see what has really been the enormous growth, particularly in the columns that are combined of satellite and hospital hemodialysis. The numbers on peritoneal dialysis and the numbers of home hemodialysis have, in an absolute sense, remained fairly static over the last 10 years or so, but haven't increased, so that there's been this dramatic increase in demand, and that's led to the situation I outlined. So what are the drivers of this? And if you think about this rather than as a disease, as a treatment system, and think, well, the number of patients or people requiring dialysis therapy at any particular point in time reflects a number of drivers. If the people who have so-called incident patients, people that have reached kidney failure and require dialysis treatment. So that's the inflow to the system. Plus there'll be some people who have had a kidney transplant, who lose transplant function and return to dialysis. And then the outflow from that pool is people who receive a transplant and therefore no longer require dialysis, or people who die. And so that you can then see this is actually a fairly simple example and sets itself up for use as a so-called Markov model. Markov's pictured in the top right, and he was a Russian mathematician back in the day when you got stuff named after you for conceptual stuff. And there's a number of other things. Many of you might have heard of Markov chains and so on. But the concept of a system, and the arrows here point to so-called transition probabilities. And you can see how fairly readily this conceptualization allows you to put numbers or rates across each of those transitions from one so-called state or one pool to another. So the first transition to talk about, and perhaps the most, the one that's had the greatest change, is just the number of new patients, or the incidence. And here I'm talking about rates per million population, because of course there's been substantial population growth over time, and that helps drive absolute numbers. But in terms of the rate per million population, you can see in this graph, going back a long time now, that there has been really until the last 6 or 7 years, quite an inexorable increase in the rate of end-stage kidney disease. So that's the first comment to make. And the second comment to make is there's very clearly, over the last 5 or 6 years, been a stabilisation of incidence rates per million population. So that's something that is important to know. If you focus a little bit on the more recent years, you can see we did think a few years ago, going back in 2005-6, that maybe we'd also reached a plateau. Whether it's around 115 or 130 per million population per year, it does seem very clear that in Australia, like in many other comparable countries, the rates have actually stabilised. So that's Australia-wide rates, and if you just remember the numbers on the y-axis, the South Australian situation is very, very comparable. We're neither particularly better off nor worse off than elsewhere in the country, with rates currently around about 125 per million population per year of new patients starting kidney failure replacement therapy programs. Just to put some international context around this, and hopefully, depending on how big your screen is, you may or may not be able to see all of these countries sorted by rate. And of course, if you look down about 60% of the way down the screen, you can see Australia and New Zealand very closely. So in fact, if you look at where we're placed compared to comparable countries, we're actually better off than most. And if you like, the leaders in the world, the United States, Mexico, Taiwan, Thailand, Singapore, Indonesia. So these are not people dying without dialysis. These are people counted who are receiving or starting dialysis programs. You can see that there is quite a dramatic difference between the rates we're seeing here and the rates there. So it's nice for many reasons not to be in the US, and this is one of them. Within that overall rate, though, there's a variety of details, and there's a bit of devil in the detail. And you can see here, again, taking this longitudinal perspective, in some respects, there's a bit of a story of nephrology here, and a bit of a story in particular around dialysis, which historically has been, if you go back to the early 80s, and you can see there was quite a low rate of the 65 plus year age group. So this is slightly the darker brown line here, and that was less than the 45 to 65 year age group, but that rate then progressively rises. And then about 10 years later, the 75 to 85 year old rate rises, and the cynics would say that's a little older than the if you like, the pioneering nephrologist. And then about 10 years after that, the 85 plus year rate starts to kick off, and then something different happens. That doesn't keep rising, and then all the rates start flattening out. And if we have time, we can talk a little bit about what may have driven that, but you can see very clearly that at an age-specific level, the ongoing increase is not particularly driven by more and more older people. It's being driven by this trend upwards in the 45 to 65 year age group. And again, just to I've mislabeled the South Australia as the right-hand panel. And again, just to put us in the national context, you can see it's much noisier data for South Australia, but effectively the same trends, perhaps a little lower rates of the older people. And I actually dropped off the 85 plus year group here just because it was added too much noise to the South Australian graph. So that's a few comments about age. And so we're seeing more patients, we're seeing more, and they're younger patients, they're in their 60s, not in their 80s. And there's an important issue here around gender as well. And you can see here, but split by age and by gender, that across all ages, and particularly in the older ages, there is an excess among male compared to females. And that excess has stabilized in the older age groups, but that 45 to 64-year age group is really continuing to diverge, and so that there's a difference there that relates to gender as well as to age. And again, we don't know from a data or registry perspective at this stage, we don't know why that might be. It might be more disease, or it might be more people going on to dialysis and choosing not to go down and fewer people choosing not to go down a dialysis pathway in one group compared to the other. We can talk a little bit later about how feasible that is as an explanation in younger age groups. But the other element to bring into all of this is, of course, as medical people, we think, okay, well, there's increasing rates of this black box of severe kidney disease. What might be driving that? And so when we collect from the clinicians the so-called primary renal disease, or a single major cause, you can see that very clearly here, and these are absolute numbers, both across the country and in South Australia. The number of people with glomerulonephritis as a group is stable, and in fact, therefore, as a proportion is dropping. The big mover here, of course, is diabetic nephropathy. The number of people with diabetes is greater than this, but in terms of diabetic nephropathy, that's, you can see, been the driver in both areas, together with a bit of an increase in the hypertensive cum vascular group. And you can then see how, well, what might you expect when you look at the different age groups and trends here, and you can see those illustrated here. And as perhaps you might expect, there are differences, again, with gender between glomerulonephritis, but you can see also that the driver for the increase in the so-called middle age, 45 to 65, is really coming from the diabetic group, not from the glomerulonephritis. I won't show you the other data, but really just please, it's diabetes that's driving this. So this is sort of data that's being collected from the ANZ data registry. So the question then is saying, okay, well, if diabetes is a driver, is it more people with diabetes and a steady proportion of people progressing to end-stage kidney disease and diabetic nephropathy? Or are we getting worse at managing the diabetes? Are more people progressing among those with diabetes? And so to address this, a few years ago, we actually did some data linkage between the ANZ data registry and the National Diabetes Registry, which is basically based off the NDSS. And this is now a little old, this data, but it really does help to answer that question. And if you look at the left-hand panel here, you can see that, unfortunately, there is a steady trickle upwards in the rate of people with type 2 diabetes who are starting end-stage kidney disease programs. And the denominator here is now not the whole population, but it's just the population with diabetes. The rate with people with type 1 diabetes is firstly a little higher, but secondly is stable over the course of this time. And you can see in the right-hand panel some of the variation around ages, which is what you would expect, given what I was showing you a moment or two ago. So there's a bit of a worrying signal here that the rates among people with type 2 diabetes are going up. And we may not be doing as well in managing type 2 diabetes as we think we do. And the other caveat to put around this is that while the left-hand panel does include all comers, because this is based on the NDSS, which in the years this was done had very limited uptake in Aboriginal controlled health organisations, this is essentially a graph of disease progression in a non-Indigenous population as well. So the other transitions that you will recall in the system are outflows from dialysis, and so one of the key outflows, of course, is to transplantation. And having mentioned earlier on that there'd been a progressive increase in a number of years in transplantation, and South Australia have been very well off. In fact, if you look at the last 3 or 4 years, the number of transplants in Australia, number of kidney transplants, I should say, has in fact stabilised, and that of course reflects the number of deceased donors. 2020 and 2021, there are some complications around COVID, of course, but in reality, we didn't lose that many transplants, and for better or for worse, in terms of, if you like, the transition from the dialysis pool to the transplant pool, or at least out of the dialysis pool in that direction, this is static at an absolute level. This is absolute numbers. Therefore, if you then use this as a denominator with use dialysis patients, so now we're looking at the number of dialysis patients per million population, you can see that starts to drop off, which is what you would expect. So that's one of the transitions out from the dialysis pool. The other transition out, of course, is death and death rates. And here there is some good news in that mortality rates among dialysis patients have steadily trickled down over the last 20 years or so. And here you can see the last 10 years illustrated. And while in some respects they don't look like enormous changes on the graph, you can see if you actually start lining them up against numbers, the first year mortality rate nationally has dropped from around 10.7% down to around 9%. So that's a substantial drop, both in terms of absolute terms and in terms of think about the effect on dialysis transition pools, and that effect is reflected across later dialysis vintages. That's good news, of course, don't get me wrong, but what it does do is when you start then to say, well, what is the answer to why do we have so many dialysis patients and why are we in such a bind? We've got an increasing number of incident patients. We've got stable absolute transplant numbers that haven't increased, and we've got an improving mortality rate. And we've also, in the metropolitan area, got very limited expansion over a number of years. And so we've ended up in this situation that I outlined earlier on. Now, I made a few comments along the way that this data comes from the ANZ data registry, and the ANZ data registry is, or the dialysis and transplant registry, is something called a clinical quality registry. And the clinical quality registries are interesting beasts. ANZ data is funded by the federal government through the Organ and Transplant Authority. And so the data that I've shown you is national data. It's inclusive of all patients. It's not a sample. It's not based on hospital separations data because, of course, in the dialysis space, there's a mixture of people that receive hospital-based treatment in public hospitals, people that receive treatment in private hospitals, and people that receive home-based treatment. And so one of the strengths of a clinical quality registry in this setting is it can relatively easily cross those boundaries and collect clinically oriented data such as that which I've shown you. And just to digress for a minute then to talk about what are registries, and I hope the motivation will become clear in a minute. So when you think about registries or clinical registries in particular, and I separate that from perhaps cancer registries, which are pathological registries, they fall into three broad groups. There's clinical quality registries, which use data for multiple causes, but particularly collect data around clinical events for the purposes of health service planning. And that's the basis of today's talk, safety and quality data and used for clinical research. There are other registries that are based around devices, and for example, pacemakers, or perhaps a better example is the joint replacement registry, which is based across the courtyard at SAMRI. And then there are rare disease registries, and there are a number of examples of those. Scleroderma registry perhaps is a good example of something that's South Australian based. And the balance between the uses of health service planning versus clinical research and safety and quality clearly vary across those categories. Having said that, there are some distinguishing characteristics for registries broadly, and they tend to collect data that's marked by breadth, a little bit of data about everybody rather than a very focused cohort study. They have standardized data collection and definitions. They generally have very high degree of clinician engagement and are often set up, at least initially, by clinicians, and they are ongoing data collection. So it's not a 3-year cohort study, it's an ongoing data collection, which may evolve over time, but that's important. And so in an ideal world, registries form an integral part of what we hope is a learning health system. It sounds a bit aspirational, I know, sometimes in the midst of a COVID pandemic, but we would hope that across the system that we all inhabit various parts of, that there is an ability to measure outcomes, identify variation, generate hypotheses, test those hypotheses, and there's a whole discussion out there about registry-based trials, and then drive the implementation of those findings, be they about novel treatments or healthcare models of care and so on, back through the routine care system, and then monitor the translation and adherence. The final comment is having talked about the couple of registries of SAHMRI, there's actually quite a large collection within the SAHMRI Registry Centre. There's about 20 clinical quality registries. Some of the big ones are us and the Joint Replacement Registry, the ROSA, the Registry of Older South Australians, all the way through to a number of smaller ones. There's a dental implant registry, for example. We are one of two large pillars. There's another large pillar at Monash, which hold a similar number of registries, and together there's a national body which exists at the moment under an ACTA umbrella that forms a registry special interest group. And at the end, I'm going to plug the fact that we're having a conference in Adelaide in November. But just to get back to the topic of the day, so having talked about what the present situation are and what the drivers are, the obvious question is, okay, well, what about the future? What do we expect to happen in the future, and how can we try and feed in and try and get out of the current situation and hopefully get into a better situation in the longer term? And so what the data that I've illustrated should allow you to do is, in fact, project the future. And there is this saying that all models are wrong, but some are useful. And the track record of projecting demand for dialysis chairs is actually pretty good. Because the trends, as you have seen, are reasonably stable over time. And so if you think about that Markov diagram with the different pools, if you think about the number of people who require dialysis treatment, for example, at the end of any given year, it will be, you can effectively calculate that by knowing the number of people at the end of the previous year, plus the new patients, minus the number of transplants, minus the number of people that die. And a more elaborate version of that is, in fact, what drives the projections process. The diagram across to the right is from the South Australian projections, which are a little simpler than the national ones because we've used larger 20-year age groups, but basically give you a good idea of what the nitty-gritty looks like. It is actually accounting. You need to make some assumptions about incidence rates, transplant rates, and mortality rates, bearing in mind that there are different denominators for each. So the incidence rate is per million population. The transplant rate is an interesting one because the number of live donor transplants is related to the number of dialysis patients, you would think, whereas the number of deceased donor transplants is actually related to the number of deaths, but more specifically the number of deaths that are eligible for donation. So that's a tricky one to get a handle of and project. And then there's the making some assumptions about the mortality rate of dialysis. So if you're prepared to make assumptions around all of those, and that is elaborate guesswork, and this is how elaborate the process is. It's actually not that elaborate. Saying, okay, well, here's an example of an age-specific incidence rates. This is what's happened over the last few years. What do we expect will happen over the next 10 years? And that's one of the factors that's been built into the national model. And then there are some other hairier ones where you've actually just got to try and get some consensus over what do people think will happen for that 70+ year age group. Having said that, if you do that, you can then roll out what you expect will happen into the future. And this is an example of work that's going to be presented next week at the Society of Nephrology conference around what we expect to happen at a national level to the number of dialysis patients. And this is broken down by age because that's important. It's important in understanding what the demand is going to be, not just for dialysis services, but for all of those other services. So, for example, people who are over 70 are much less likely to have a kidney transplant than people who are under 70. They're much more likely, on the other hand, to have a bunch of other comorbidities. And so you can see that this starts to get into, at a federal level, I guess, funding, and at a state level, the issues around planning is at 2021, there were just under 6,000 70+ year olds on dialysis. In 10 years' time, there's going to be about 8,000. So there's going to be 2,000 more people, and somewhere along the line, they're going to need to be cared for, and there's going to need to be the infrastructure to care for those. And you can then go on, and by linking the age groups with the age-specific proportions of people who are on home dialysis versus satellite dialysis and so on, you can then generate graphs such as this, and you can then calculate, based on the number of people that we expect to be receiving hospital hemodialysis, satellite hemodialysis, what the number of dialysis chairs, if you like, or what the scope for peritoneal dialysis facilities required will be in 5 years' time and 10 years' time. So there's some frightening numbers if you're funding treatments that cost $50,000 to $80,000 a year. The drivers have changed, though, perhaps as you might expect, given those incidents. It's actually largely the largely the population expansion that's driving those numbers. And this is a table again from the national projections, so that the middle column here is the proportion or the percentage increase from 2020 to 2030. But you can see that, particularly in that 70-plus-year-old group, while we're anticipating almost a 40% increase, the great majority of that is actually driven by population growth, whereas if you come to these younger age groups, and this makes sense now when you look at that rising incidence in that age group, you see that a much greater proportion of the increase in the dialysis population is not explained by the general population increase, but is in fact an increased rate of kidney disease per million population. So that's the national data. We've, over the last couple of years, with the renal community of practice, been deeply involved in collaboration with the department in Hindmarsh Square in looking at South Australia and some South Australian projections. And you'll see some of the challenges for this are illustrated in that graph on the right. Because we're a smaller population, the numbers do very much bounce around a lot. But when you do the same exercise, you can see that the predicted increase in the number of dialysis patients from around about the current level of around about 1,000 will be to a little over 1,100 in 2026 and around 1,300 in 2032. And so if you follow the various maths, you can see that's outlined in the bottom, that we're going to need to be finding some substantial increases in facilities over the next few years. And that's the growth that's over and above, if you like, the present gap or the present lap. So that all sounds, I guess, pretty depressing, and certainly is a challenge for the health service and health service funders. I just wanted to finish, though, by just illustrating some of the other things you can do with this sort of an approach to modelling, and some of the perhaps optimism there. And this is some work that we did with our colleagues at the Baker a year or two ago, and building on that linkage with the diabetes register and saying, okay, well, if you implement a couple of interventions that we know from evidence elsewhere work, what might you expect in changes in the rates of end-stage kidney disease? And the two interventions that we modelled were a combination of a lifestyle modification program and a sugar-sweetened beverage tax. And there's actually a reasonable amount of evidence in the public health literature that works to some extent. Clearly not everybody takes up the lifestyle modification. Sugar-sweetened beverage tax certainly does knock off or reduce the rate of sugar consumption. But importantly, for this purpose, there is reasonable evidence from overseas about the take-up and the effect of that on this transition from the general population, in particular pre-diabetes to diabetes. And then you will all be very well aware of the impact of SGLT2 inhibitors, empagliflozin and dapagliflozin. And so we modelled the effect of the introduction of both of those on the trends, not in all-cause kidney disease, but in the diabetic nephropathy. And you can see, firstly, that there's some encouraging trends here, whether you look at the left-hand column, which is the optimistic sorry, the left-hand one's the realistic scenario, and the right-hand column is the overly optimistic one, particularly around uptake of lifestyle modifications one. But you can see that the SGLT2 inhibitors very much do deliver a return, if you like, in terms of a reduction in rates of disease within a 5 to 10 year time frame, whereas the introduction of public health measures, as you would expect, would operate upstream, really does have a delayed impact a number of years down the track. But that you can, in theory, drop the number of new cases with diabetic nephropathy by a very substantial amount in the next 20 years. So there is, if you like, a degree of optimism out there that the predictions that I've made in the longer term may bend. So what I hope to have shown you is really a little bit about what to expect in the future, that there is going to be ongoing growth among dialysis patients. There is going to be substantial growth. It is actually going to exceed the population growth, and there's going to be an increasing proportion of those overall dialysis cohort that are older patients, simply driven by the aging of the population. There are some opportunities to intervene, as I've outlined, but they're going to have delayed payoffs. And so the challenge for us as a system is saying, okay, we're going to need to meet the current demands and then the demands of the next 5 or 10 years, and also make sure that we're implementing those measures so that the 10 to 15 to 20-year horizon, so that those curves start to bend rather than continuing to go up and up and up. And finally, just to bring this back to the very local and practical thing, all of those models have been pulled together into a statewide renal dialysis services plan, which is in draft form and is going to Cabinet in the next few weeks, together with an infrastructure request for around 112 dialysis chairs for South Australia over the term of that plan, predominantly in metropolitan Adelaide, and that will hopefully address current mismatches and future needs, and has got a number of other important elements in there as well, around including substantial sections around workforce, around cultural safety, and around increasing the support for and uptake of home therapies. And so the final comment, and it's just loop back to my earlier comments about registries, is that we are holding the first annual Australian Registry Annual Scientific Meeting in Adelaide at SAMRI in early November. So if anybody's interested in coming along, please jump onto the ACTA website, have a look at the program. We would love to see you. So I'd like to acknowledge the Anstarter crew, the Anstarter team who are there, and also Jane Wilkie and Jay Westling, who are the stalwarts who support the renal community of practice. And happy to take any questions or add any other comments if I've left anything off. Thank you.
Brilliant. Thank you very much for that. We've got a couple of questions that have come through over the course of that, so I might put those to you first on behalf of those that asked them, and then we'll invite some more people as we go. So quite early on, whilst some of the Jane Angie's there, would you like to ask your own question rather than have me read it?
Yeah, sure. Look, thank you.
Jane.
Can you hear me?
Yep.
Okay. Stephen, when you showed that data that was the split between males and females, there's a couple of things that kind of jumped out, because we know that men actually consult with their doctors less often than women it's the same in bowel cancer and things like that. We also have quite a lot of data in chronic disease management in IBD that men are less likely to be adherent and over long periods of time with advice. Do you think that's happening with the diabetes and the hypertension, and that might account for men? Or do you think that maybe nephrologists are less likely to offer dialysis to women? I mean, what do you think is happening there? It's fascinating.
So it is, and the answer is a bit of column A and a bit of column B. So there is evidence. I'm sure many people know that there's poorer engagement with health systems, and certainly more rapid rates of progression of kidney disease in males than females, but there is also a difference in uptake of dialysis, particularly the older age group, and we've actually looked at that. I won't show you the data today. We've looked at that by linkage of the registry with death certificates, and looking at people that are said to have died of end-stage kidney disease and whether or not they received dialysis, and there is that differential at the older end of the age spectrum. This is the 8, and I'd also add parenthetically that well over 50% of 80-plus-year-olds never even come near a nephrologist or a registry if you're going that data, but there is a gender split there, so it's a bit of everything. And there are so there's our underlying disease issues, also different diseases. Some of the, for example, lupus has a female predominance. Some of the Allports has a male predominance, and so on. So there are those gender specific splits as well. The purest example perhaps to look at is polycystic kidney disease, though, which obviously is autosomal dominant and still preserves that sex differential.
Thanks.
Patrick Russell has asked in the chat, could you please comment on patient consent for a clinical registry with a specific bit of whether it's opt-in or opt-out?
Sure. So opt-out, and almost all registries are opt out, and there's widespread national precedent, and in fact that is this has been for well over 15 years the settled policy of the Safety and Quality Commission's what started off as standards and are now still standards, or there's, you know, it is policy. There is, however, quite there's a new, as in late last year, new federal government discussion paper that's ongoing about really trying to shift the whole paradigm of clinical quality registries out of the research framework, and it's going to be interesting to see how it goes, because there's entrenched interest every which way, but is saying, okay, well, the primary function why many of them are funded is in fact not clinical research, but safety and quality and health service planning, and in that sense it doesn't fit well within a very research-based consent paradigm, and I think that's the discussion that's going to have a little way to run. But if you come to the meeting in November, you'll hear some presentations, including from the Federal Department of Health, around their proposals around that. And perhaps just to roll on to Patrick's other question, can you please describe the governance of the ANZ data registry? And like all clinical quality registries, I think it's critical that the clinical part is important, and there's always a few variations, but generally clinical quality registries have a strong steering committee or governance group that is led by clinicians, and typically would have an embedded link, and that may be, for example, the Orthopaedic Association technically own the joint replacement registry. That's not the case with ANZ data, but we have a very strong link with the Society of Nephrology, and that's important in terms of providing clinical governance. And then there's a separate element of governance, which is really around data governance, and that means, and most registries would either have some form of structure that has a series of protocols and a group that act as guarantors and data custodians, so that if there's a request for data, that there's an appropriate set of governance procedures around that.
I don't know if anyone else would like to turn on their camera or raise their hand. While people are thinking, I'd just like to jump in quickly. I thought that was great. It was almost a throwaway line, but that bit where some of the terminology being used is being driven by patient interest groups to shift that. Is that something where the clinicians have invited patient groups, or more?
Chris, that's a fantastic Dorothy Dixer, Chris. So those of you who were at the last Grand Round, I think I gave last year, we actually gave a joint presentation with a series of our patient partners. And one of the wonderful things, and it's come more out of the research space and the clinical space, one of the wonderful things in kidney disease has been the patient engagement over the last few years. So now, as a routine for all of our research activities, we would have a degree of patient involvement, and that varies a little bit, obviously, depending on the nature of the project, but we would routinely have a group of patients that will provide us with some guidance on particular areas of relevance. And we're now at a stage where, as a registry, we have a large, if you like, patient panel, and so when there are particular, as well as providing overall guidance, when there's particular projects that are suggested, we would simply send an EOI around. So perhaps to give an example that might be germane to this, we've been doing some work looking at the travel time, both distance and time, based on Google Maps, that people spend going back and forth to dialysis, so that's clearly something that's really relevant to patients. But when and even mundane things like, we can put that into tables and say, look, less than 15 minutes, 15 to 30 minutes, 30 to 45 minutes, but I'm not the person doing the traveling, and it's just really interesting seeing what people regard as acceptable. And we've had discussions around, should it be 20 minutes, should it be 40 minutes, but that sort of input is just part of it, together with much more other interesting concepts. So one of the other core roles of a clinical quality registry is producing output about sense-specific outcomes. And so in conjunction with the Society of Nephrology, we're now about to put out an expanded range of quality indicators. But for a number of years, you've been able to go and look up, for example, at the Royal Adelaide, our transplant outcome rates, our dialysis outcome rates. what we don't know is the effect of that, if you like, the impact of that on patients. And so if I'm going to put out data that says your chance of getting on the transplant wait listing in Adelaide is better than in Melbourne, well, that's all well and good, but does that help the patient? There's a whole story there about does it, and how do you present it, of course, but even beyond that is saying, okay, well, you need to think about that story. So there's a whole series of research agendas that the patient involvement does take down. And the other comment is that I get back to Patrick's one, is that you need to include patients in that governance process, and how you do that needs some careful thought. The traditional hospital approach is to tap one or two people on the shoulder and put them on a committee, and gee, that sort of works, but it's actually, you know, I don't know, I've never been asked to be the sole spokesperson for a large group of heterogeneous people before, and I think there's, you know, we've been experimenting with a lot of different models about having larger groups. It's a long answer to a short question, Chris.
Thank you. Any more? Raise your hands or put something in the chat, or whatever works best for you.
I should also add, just on the page thing, if you're interested more, if you type in, SAMRI actually have a so-called consumer community of practice, which is quite active, and that's based around the health translation SA, and we have a substantial involvement in that.
Well, I think you've satisfied everyone's curiosity, so it just remains for me to say thank you again on behalf of everybody, and thank you all for joining us, and we look forward to seeing you again next week.
Thanks, Chris. Thank you, everybody.